so they can see me.
Yeah,
Oh.
see you.
Good morning. My name is Trina Miller, and I am here at the Department for Public Health, the Prenatal Program Coordinator, and I appreciate all of you joining us through the ITV for taking time out today to be a part of this and to participate. And we definitely do want to let you participate in this, and as we do presentations, ask questions and share experiences, and want this to be beneficial for you and your staff and for your health department and community. So we're very thankful for each of you and for what you all do in the clinic, in your community, each and every day. So I want to thank you for that. This is going to be an exciting day. We have several topics that we're going to talk about around the area of pregnancy and substance use. And we know that that's an issue here in Kentucky and other areas also. But we know it's something that we need to address. And so this is something that we are working on, and we appreciate your work on this also. I will be sharing about some of the program updates regarding the prenatal program at the end of the day, but we have several other speakers today that are going to be very engaging and exciting and have a great group of professionals with us. So I want to thank them for coming, and I look forward to hearing them share also. And if there is anything that you, like I said, need during the presentation, to make sure to contact, as Jo Allen said. And if you need assistance, you can always, I sent my cell phone number out that you can utilize that if you would need to contact me for some reason. So just a brief history of myself is that I'm been here at this position for 6 years as a prenatal program coordinator. Prior to that, I'm a registered nurse, and I've worked primarily in labor and delivery, nursery, postpartum for about 9 years, and a few years of some med-surg prior to that. So moms and babies are certainly my passion, and I appreciate being able to continue that passion here at DPH. So through the course of working here at DPH, I met our first speaker, Kristen Ashford, and many of you may have heard her other times. She works, has worked with our GIFTS program. She works through other smoking cessation programs, one of her specialties, works with our prenatal training here, and does an excellent job. And I'll let Kristen share more about herself, but she works in research, has written articles, has won awards, and so we are very grateful. She is an associate professor at the University of Kentucky, the College of Nursing, and I'll let her share about her background and experience, and she'll be our first speaker of the day.
Thank you, Trina. I'm going to go ahead and pull up my PowerPoint. There it is, right there. Well, while that's getting pulled up, I wanted to give you a little bit more information about myself. I actually also, like Trina, started in labor and delivery, and that is my passion. I worked labor and delivery for about 10 years. And then I became a nurse practitioner, high-risk OB, and loved that. And in that time when I was a high-risk OB nurse practitioner, I was asked to do some clinical groups in the obstetrics department at the University of Kentucky. So I got connected with UK College of Nursing, and from there I was able to become the course coordinator for obstetrics and women's health. And now primarily my job is doing research, and my area of research is preterm birth. And certainly you cannot talk about preterm birth without talking about substance abuse, because women that use drugs and alcohol during pregnancies are more prone to have high-risk pregnancies and preterm birth. So what I'm going to do today is just give you a brief overview of some of the key concepts in pharmacology related to substance abuse and pregnancy. I'm going to only just preliminarily introduce those concepts because we are blessed with experts in the room today that are going to talk more in depth about opiate addiction, alcohol, fetal alcohol syndrome, and support. So my passion is really tobacco use, tobacco use and secondhand smoke in pregnancy. So I'm going to share a little bit of research we did in your communities about tobacco use and substance abuse in Kentucky. So what we do know, and who governs all of the obstetrics care really, is the American College of Obstetricians and Gynecologists. And they do recognize that substance abuse is one of the most important risk encounters in OB, and that all patients should be screened thoroughly about alcohol and tobacco use and opiate addiction at their very first prenatal appointment. Prevalence, we do know nationwide that about 12% of pregnant mothers smoke, and you probably know that Kentucky battles every year with West Virginia to actually see who has the most pregnant smokers, and I'm happy to say that West Virginia won, and we are second to West Virginia, and we have about 25% of pregnant women smoke in Kentucky, which again, nothing to be proud of, but at least we did not get that #1 seed. 10% report alcohol consumption, and I'm sure Laura will tell us about Kentucky stats. 4% drink binging, and even at least 1% heavy alcohol use. And that again is national statistics. And 5% nationally report illicit drug use during pregnancy. Risk factors for substance abuse, and it probably is of no surprise, psychosocial factors. For example, depression, anxiety, low socioeconomic status, low education, or family history, and any other psychiatric or sexual abuse. There's certainly barriers and legal implications regarding substance abuse in pregnancy. Some of these women are afraid to actually disclose this during pregnancy for fear of losing custody. Negative feedback from providers, afraid that they may not get the care that they should get. And just to be honest, prenatal care is not tailored to women with substance abuse. So we really need to re-examine the way we do prenatal care with women with addiction. There again is legal considerations, especially with those of illegal substances, marijuana, cocaine, opiates, and we do know that what I was just talking to with Michelle, who is the expert in opiate addiction and pregnancy, she said that heroin addiction is really more than anything on the rise here in Kentucky. What do we usually do to help these women that are addicted? Well, we want to get them treatment. We want to get them support. The drugs of choice for opiate addiction is typically Subutex or methadone. Patients are typically, initially, if they are addicted, are going to be put in inpatient treatment centers, but as you know, there can be barriers to getting women in treatment. So the purpose of getting women on methadone or Subutex is to be able to monitor them and to provide adequate prenatal care during pregnancy. Certainly, there are concerns about immediate withdrawal of the medication, so you don't want to do a tapering effect during pregnancy, but again, we'll talk about that later in more detail later in the afternoon. Also, methadone and Subutex certainly are not without concerns on risks of the fetus. There are also very real issues about withdrawal and neonatal abstinence syndrome after delivery. And also, these kind of drugs can affect the fetus during labor. Even if you're monitoring a patient in labor and delivery and you have the mom on the fetal heart rate tracing, you can see limited heart rate variability when moms have been taking Subutex or methadone, as well as if a patient comes in and is not been maintained on Subutex or methadone, and they may have had a binge of heroin or even alcohol, they are more at risk for placental abnormalities or placental bleeding. So they can come in and have a emergent type of condition, most likely placenta abruption, which we know is life-threatening to the mother and the fetus. So advantages of Subutex over methadone, there are a few. There's a lower risk of overdose, fewer drug interactions. They can be treated on an out basis without essentially a daily visit by a licensed program, and there's less severe neonatal abstinence syndrome. Disadvantages, they are more prone to hepatic dysfunction. We don't really have a lot of long-term data on the effects of infant and child effects on Subutex because it's newer than methadone. There's a increased dropout rate due to dissatisfaction with the drug, and an increased risk for diversion, which means sharing or selling the prescribed medication. There is, again, limited research. However, there was a randomized clinical trial in 2010 comparing the effects, or the neonatal effects, of Subutex and methadone. And what they found is that 89% there was an 89% decrease in morphine let me say this again. It took 89% less morphine to treat neonatal abstinence syndrome in those that took Subutex versus methadone. Those that took Subutex had a 43% shorter hospital stay, and 58% had a shorter duration of medical treatment for neonatal abstinence syndrome. Again, the plans and treatment and care and support that these women will need will be covered later on in the program, but initially, overall, what you need to do is screen and identify these women. The first thing you have to do is get these women to trust you, get these women to disclose, and then get them support that they need. You have to determine the person's readiness to change, and then start appropriate nursing or medical interventions. And all through that time, when you're initially meeting these women, you're going to be using the concept of motivational interviewing to get them to disclose. A little bit about cocaine. In a recent meta-analysis of 33 clinical studies, we found that initially in the meta-analysis, they took all the studies that have ever been done on cocaine and pregnancy. And of course, those studies had to meet certain minimal criteria. They had to be evidence-based. They were thoroughly reviewed and selected based on if they were randomized clinical trial. And so they were organized into 4 main groups. Studies that looked at just mainly cocaine, use of mainly cocaine, use of women that use cocaine plus other drug use but no cocaine, and then no drug use. And what they found is that when cocaine-exposed children were compared to those with no exposure, the cocaine-exposed women had higher risks of congenital malformations, low birth weight, prematurity, placental abruption again, which we know is life-threatening to both the mother and the fetus, premature rupture of membranes, and decreased length and head circumference. But comparison of cocaine-exposed children to children with polyuse without cocaine, so people that used other drugs without using cocaine, that the only risk associated with that was placental abruption and premature rupture of membranes. And certainly we know that there's many other adverse perinatal effects attributed to cocaine, but certainly when you use the two together, it's going to produce worse outcomes for both the mother and the infant. We did also already mention substance abuse and neonatal narcotics abstinence. Again, this is really dealing with the effects of the infant and the withdrawal of the infant after delivery. What we do know is that these infants are much more at risk for respiratory issues after birth because they have increased mucus production. Also, these infants have a less effective cry. And so if they're not able to cry and really get rid of that extra fluid and mucus, they're going to be more prone to tachycardia, tachypnea, and more risk for respiratory distress syndrome. When they are going withdrawal, which typically occurs in the infant within 24 to 72 hours, what we do know is that they have, again, a more distinctive cry, which is high-pitched, shrill. It sounds like a painful cry, and it's inconsolable. They just are inconsolable. Methadone, they can have actually a more severe and prolonged withdrawal. However, the effects of being on methadone and Subutex during pregnancy outweigh the effects of neonatal abstinence syndrome. Because if the mothers did not get Subutex or methadone during pregnancy, they may have had an increased risk for stillbirth due to their use patterns. They can, binge and not binge, and that certainly can be more detrimental to the pregnancy than after delivery and withdrawal. These infants are also more jittery, hyperactive. We already said inconsolable. Very characteristic of withdrawal is sneezing and yawning excessively. And I'm sure some of you, if you have worked in labor and delivery or the nursery or seen these babies come into the health department after, you may also recognize that. And they also have depressed reflexes. And so certainly one of the assessments that we use to determine the infant is cognitively appropriate is that we test the reflexes. We test their moral reflex, their grip reflex, their suck reflex, and even their suck reflex can be diminished, which has implications on feeding. So these infants are also more likely to have difficulty breastfeeding. Which brings up the question, which I'll just briefly mention, is that should these women be breastfeeding? Well, certainly if they're using illegal drugs, cocaine or binging, they absolutely should not be breastfeeding. But if they're being maintained on methadone or Subutex, ACOG still does recommend breastfeeding. And so that's just a brief overview of some of the concepts we're going to talk about today. Certainly I didn't talk much about alcohol or opiates, and that's going to be in depth later on this afternoon. And what I want to do at the end of this presentation is really share my passion and my clinical research related to other types of substances that are not illegal, but certainly tobacco and secondhand smoke are substances that do cause detrimental effects on both the mother and the newborn. So what essentially sparked my clinical research was my everyday experience working in labor and delivery. I also was an OB case manager, and so part of my job every day was rounding on high-risk pregnancies. And so when I rounded, I was able to see similar patterns with these women, and the pattern that really emerged was these women were in homes that most of their family members smoked or they were smoking themselves. And part of my job was to give a tour of the NICU. And it was really sad that I had to go up and show these parents, these infants, and you know, they saw that they were going to be more at risk for delivering a preterm infant. So I really wanted to find a better way, really get to why these women that were smoking during pregnancy, why they couldn't quit, or why if they had a high-risk pregnancy, why the next pregnancy they were still unable to quit. What we do know about tobacco use is that it is the single most modifiable cause of poor pregnancy outcome. Nothing more could decrease an adverse pregnancy outcome than quitting smoking during pregnancy. We talked about the U.S. rate in Kentucky, again, is about 1 in 4 women smoke. And in some of the counties, especially in eastern Kentucky, we have rates as high as 50% of pregnant women smoke. We do know that pregnancy is the most opportune time to quit smoking. It's a very teachable moment. And so it's a wonderful way for healthcare providers, especially in the health department, when you're seeing these women come in, to really at each time point touch them and ask them that question. Just asking them at each prenatal appointment will impact them. They may not quit that first time, that second time, that third time, but sometime throughout the pregnancy, they're much more likely to reduce or quit smoking if they are asked at each visit. Nearly 1/4 of women do quit smoking when becoming pregnant. Smoking during pregnancy, we know, again, causes pretty much every type of problem and puts them at risk for any type of pregnancy problem. Most commonly, premature rupture of membranes, preterm delivery, low birth weight infant, or small for gestational age. Again, my passion is also secondhand smoke. And so we do know that secondhand smoke is very unsafe as well. There are 4,000 chemicals, most of which are carcinogens, and we know that women that do not smoke, that inhale secondhand smoke, are more likely to have women that do not smoke that are exposed to secondhand smoke are more likely to have infants with congenital anomalies and have increased incidence of SIDS after delivery. Also, 3,000 people die each year that are exposed to secondhand smoke that do not smoke directly. And 22 million U.S. children are exposed to passive smoke, and most of that begins in the womb. Why pregnant moms smoke and quit? Well, the majority of women quit is, they say, to protect their unborn baby. So we do know that using the pregnancy as a time to say this will help you and your baby does have impact. I did mention that about 1/4 of women do stop smoking during pregnancy, but the sad part is 2/3, nearly 67%, relapse within 1 year of delivery. And I think some of the teachable moments we're missing in the clinics are that, yes, smoking during pregnancy certainly does decrease your risk or adverse effects on the infant, but equally amount of adverse health effects can be on the infant after the baby's born. Increased risk for respiratory illnesses, SIDS, which is death, and as well as, ear infections and irritable bowel. Part of my research, I had to develop a model, and this was very busy, and I wouldn't ask anybody to actually try to understand it, but I do want to just talk a little bit about how we know secondhand smoke is bad. So if you look in the top corner where it says maternal exposure, moms can inhale secondhand smoke from their home, from their work, or from social environments. And then if you go over where it says uteroplacental hypoxia, after a mom that does not typically primarily smoke, after she inhales secondhand smoke, it goes to not only all of her organs, but it also goes through to the placenta. This causes hypoxia, a decreased amount of oxygenation. The vessels are constricted. So that alone, a decreased constriction of the blood vessels is not good for several reasons. For one, that's what gives the infant nutrients and gives the infant oxygen. But also, what is bad about the secondhand smoke is that there's nicotine in this smoke. And nicotine is a drug who has a molecular structure that just easily passes across the placenta. A lot of drugs, the placenta blocks the effect to the fetus, but nicotine easily diffuses across that placenta. How do we know that? Well, we know from looking at tissues in the infant of non-smokers, because nicotine can be absorbed through the fetal skin, inhaled via the amniotic fluid, and it can be directly transported to the fetus through the umbilical cord vessels. And this has been shown because we confirmed that moms did not smoke. And after delivery, we find nicotine in the placenta, in fetal hair, in fetal urine, meconium, and cord blood, and now even in toenails. So somebody might ask, well, what if the mom, how do you know for sure that the mom did not smoke? Well, because we confirmed that she did not smoke before delivery by looking at her urine. And so most moms, I would not say most, let me back up. About a quarter of moms do not disclose their smoking in early pregnancy. And so just asking them, do you smoke, that does get them thinking about it. But if we were going to look at the outcomes, we would need to biochemically validate if they smoked or not because of the high deception rates. And we did that by looking at their urine during pregnancy to make sure we didn't see any cotinine in their urine. Then after delivery, we looked at the fetal tissues and did find nicotine in their fetal tissues. Women that did not, and this was a previous study I did, women that did not smoke, that had secondhand smoke in their home, were equally as likely for their infants to be admitted to the NICU and equally as likely as their infants to have preterm, or for them to experience preterm birth. And we looked at hair samples to determine that. And so, again, it's very important to continually ask these women why they're smoking or why they quit. And when I did a qualitative study, and I actually interviewed women that were successful not quitting, and I'm telling you, in Kentucky, that was hard, to find women that were successful not relapsing. And their primary motive for why they were successful, this is what they told me, is that, again, like we research knew before, the child's health was a primary motivator. The second reason was they demanded a smoke-free environment. And so eliminating that smoking in their home primarily really helped them stay quit. Also, from the women's own words, their smoking perception changed from one of comfort. They smoked because it was comfortable, it reduced their stress, it decreased their anxiety, and that changed. And then they viewed smoking as one of just being, they used the word disgust. Also, very importantly, cessation was viewed as a lifelong change. Many women that did relapse and did go back to smoking, just said, well, I'm just going to quit for smoking. Or I'm sorry, I'm just going to quit for the pregnancy. But the woman that, when they quit during pregnancy, said, I want to stay quit, and they substituted their smoking behaviors with new behaviors, they were more likely to not relapse. And some of the behaviors that they adopt is that they go out and after dinner, instead of going to have a cigarette, they would wash the dishes. Or after dinner, they would go for a walk. Or they would, again, replace that smoking behavior with a new, more healthy behavior. I'm a little bit out of time, but Sarah told me earlier that I could go over a little bit.